we're going to be moving into the Texas Tech part of our program, as the last two speakers are from the University of TT. Starting out with Dr. Eddie Wells. Originally born in Bulgaria, graduated from the Medical University of Sofia. That's my young son who's banging outside my door. Completed residency of emergency medicine at the University of Virginia. She is an associate professor of emergency medicine, as well as the residency program director for the Texas Tech University of Health Sciences. Dr. Eddie Wells, we'll send it all over to you, and Благодаря for being here. Thank you.
Hola, you're welcome. Thank you very much for inviting me. It's a real honor, and I'm really excited to be part of this conference for the first time, and I hope it becomes an annual thing for me. One of the reasons I got invited was because after graduating from my residency at the University of Virginia, I did 3 years of medically underserved area in Truth or Consequences, New Mexico. So I got to experience the big jump from the big university center into the middle of nowhere, being the only board certified doc in town. So it was very exciting. So I have no financial disclosures. I would like to thank specifically some of my colleagues here at the University of the Texas Tech University who helped me with putting this talk together. Dr. Brown at our department, who's been a great resource on EMTALA related information, Dr. Tyrok, of course, our trauma chief, and Dr. Mukherjee with cardiology, and Dr. Zuckerman and Robles with GI, Dr. Cruz with neurology, and Michelle with OBGYN. So lots of this talk is created based on literature, but also on experience from our colleagues here. So here, briefly, the objectives. We'll talk a little bit about our favorite EMTALA and stabilization, and how do we communicate about our transfers. So in favor of time, first of all, what is EMTALA? This is a statute, a federal statute that governs when and how we can refuse treatment to patients, or we can transfer them from one hospital to another, even if they are not quite stabilized yet. So this is part of the Consolidated Omnibus Budget Reconciliation Act, also known as the COBRA law. And importantly, it applies only to participating hospitals. But basically, almost all hospitals are participating hospitals, because as long as they're accepting payments from the Department of Health and Human Sciences, from CMS under the Medicare, they really are participating hospitals. So we are all kind of obligated to act under EMTALA. So very briefly, EMTALA covers that any patient who comes to the emergency department. So the reason I put the 250-yard sphere there is because if something happens within 250 yards sphere of the actual dedicated emergency department, the EMTALA goes into effect only if a patient who ends up being outside the emergency department and in the 250-yard sphere requests an emergency treatment, and any prudent person would be able to say that, yes, that person really is in need of emergency treatment. So anyway, so any patient who comes to the emergency department requesting an examination for a medical condition must be provided with an appropriate medical screening examination to determine if he's suffering from emergency medical condition. So who can do the medical screening examination? Every hospital has to have designated medical professionals to do that. Well, could that be anybody else but a physician? The short answer to that question would be that anybody, if it's anyone else but a physician, even if they're designated, it exposes us at more risk of kind of reprimand by the EMTALA rule if anything bad happens with the patient. So if we find that they have an emergency medical condition, the hospital is obligated to provide a treatment until the patient is stable, or to transfer him or her to another hospital in conformance with EMTALA. In other words, the transfer has to be appropriate. So what is an appropriate transfer? This is when we have stabilized the patient to the best of our capability at our facility. No further stabilization can be provided because of the resources we have or have not. And the risks of transferring the patient to the accepting facility are lower than the benefits of the transfer. And of course, the accepting facility should have accepted already that patient, and we should have communicated that, and we should have ensured a proper type of transportation safely to the other facility. So when COVID came about, COVID came up with a little, EMTALA came up with a little guidance, which is by no means a waiver of EMTALA. EMTALA is still completely valid throughout this thing, but what they allowed us is to have alternative locations for doing the medical screening exam. And these alternative locations could be on campus of hospitals or off campus. And the ones that are on campus are under EMTALA. They're operating under EMTALA. And the individuals, they could actually be screened before the individuals even came to the hospital or to the emergency department. Once they are at the emergency department, though, we cannot refer them to those off-campus areas, which are, or any kind of alternative areas. So then the other thing is that the community and the hospitals can advertise these off-campus sites for screening, but by no means there should be any kind of sign that is preventing or is perceived to be preventing access of people with potential COVID to come to the emergency department. So should be very careful with those signs, and of course a little bit more lenience with the complaints that might come under EMTALA during this time, because the EMTALA is going to look at the CDC guidance and state and public health directions at the time of these occurrences. Anyway, so without much ado, let's cover some special situations of transfers. So for trauma transfers, of course, as for all other transfers, if a transfer is needed, expedite the arrangement. Make sure that this is a proper transfer and stabilize whenever if possible, as much as possible, and do not delay to obtain tests. So this will be kind of a repetitive thing throughout this talk. Do not delay. So the Rural Trauma Development Team created through the American College of Surgeons Committee on Trauma in 2010 an interfacility transfer of injured patients guidelines, which are being used in rural communities for inter-hospital triage. So briefly to cover the different systems and criteria under that guidance, any kind of penetrating injury with depressed skull fracture, open injury with or without leak, low GCS or deteriorating GCS, and anytime there are lateralizing signs or spinal cord injury, signs of spinal cord injury, this is an appropriate transfer. Pelvic or abdomen injuries, if there is, of course, unstable ring, if there's shock associated with the pelvic fracture, any open pelvic fracture, and any solid organ injury in association with a pelvic fracture qualify for the transfer. Extremity, extremity injuries, if any kind of fracture dislocations with loss of, with any kind of neurovascular compromise distally, as well as open long bone fractures, and crush injuries, or if there was a prolonged extrication process with prolonged limb ischemia before the patient came to the emergency department. In case of chest trauma, widened mediastinum is always a concern, as well as major chest wall injury with pulmonary contusion, things like flail chest, severe hypoxia with pulmonary contusions, cardiac injury, whether it's blunt or penetrating, patients who are expected to be on prolonged mechanical ventilation also qualify. And of course, complex situations with people with multi-system trauma, burns in combination with other injuries. Of course, we should not forget burn trauma is always a trauma patient first. So all the other injuries should be stabilized because the burn can wait. And of course, we should think of whether this patient belongs in a burn center rather than the closest trauma center, because not every trauma center is a burn center. And the extremes of age, very, very young children and the elderly, people with severe comorbidities. Pregnancy is a special consideration. We'll talk about this a little bit later. And people who were admitted at an outside facility, but they suffer secondary deterioration as a result of their trauma injuries, they also qualify for this transfer. So what should we communicate to our trauma colleagues when we're transferring people to the trauma centers? There is a quick mnemonic from the current ATLS guidelines. And first of all, it's very important to communicate right away the ABCs and what interventions were immediately needed. And then we follow the usual S-bar communication. In this case, the situation will be the patient's age and the initial evaluation. The background would be any kind of important and details of the event and how the injury occurred, as well as imaging performed and results that we have found. The assessment would be the current vital signs and the most pertinent current findings on the physical exam, and the recommendation would be what kind of transportation we think is most appropriate for this patient, and any kind of interventions that might be necessary during the transport. So that covers briefly trauma. These are some of our residents during our AWLS class, which we do every summer. So I'm not promoting anything with any of my pictures here, but I just love that the slide from one of the free sites. So whenever we're going to talk about STEMI. So STEMI transfers, as we know, time is a very important thing, as with all other transfers. But in this situation, if thrombolytics are considered, they should be given within 30 minutes after the patient arrives to the emergency department. Of course, they have more complications than percutaneous coronary intervention. And so when the primary PCI is the treatment of choice, we need to comply with the door to balloon time of less than 90 minutes. If we cannot do this at the facility where the patient presents first, we should consider thrombolytics within 30 minutes. If we will be transferring the patient to a coronary intervention center, we need to get going within 30 minutes of the arrival of the patient. These are according some of the main guidelines. And a very important thing, what is the indication for transferring a STEMI patient? It is a documented or suspected STEMI. And we need to be cognizant of the importance of time. So let's not prove that this is really truly a STEMI. Better transfer when we're suspecting a STEMI rather than wait to prove that. So what do we do? First, we contact the cardiac intervention center, and then we notify parallel to that the kind of ambulance service that we're going to be using. Portable chest x-ray is recommended if there is time to see if that's a big mediastinum and maybe that's something else than a STEMI. And all the transport documentation should be done very, very rapidly. So important to notify our cardiac intervention center colleague of time of the symptoms onset, because we need to see which kind of time frame we're going to fit in, the duration of the pain, the age, and if we're aware of their code status, any kind of history of prior interventions due to MI, would it STEMI or CABG, and if they have history of renal failure because of the contrast and other interventions and situations that will be necessary. If CPR was performed, is the patient intubated, and if there were any pre-hospital significant interventions like defib. And of course, send the image of the STEMI EKG right away. Other thing, don't delay for obtaining studies, but also very important, talk to the cardiologist about the medications that they might recommend. Do not delay transport to do labs, and avoid any kind of IV drips if possible, unless the cardiologist would prefer that you start some of those IV drips. So times, it's very important if you to send a consent for treatment, release of medical records if it's appropriate, and all the assessment forms that you have from your treatment there, and a data sheet. These are things that you may send later, but you need to document some very important times. The time of onset of the symptoms, the time the first EKG was obtained, whether it was in your department or by EMS, the arrival at your emergency department, the time when you called the cardiologist, and the time any kind of medications were administered, as well as the time of departure if you're from your emergency department. These all have to be on your documentation, and transport the patient with a copy of all these studies that you already have in the data sheet, as well as the copies of EKGs, which hopefully you have already sent in advance. So again, do not delay for labs and all these. Some of those things you can send while the patient is already en route. Okay, so much for the STEMIs now. So let's cover a little bit of GI bleeds here. So common sense, keep them NPO, place 2 large bore IVs, and administer a dose of pantoprazole. So there are some more special cases of GI bleeds, though, and we are in an area where we see a lot of cirrhosis. And one of my colleagues here, Bob Kilgo, likes to say that we're not only a level 1 trauma center, but we're also a level 1 paracentesis center. So it's unusual for our interns not to have had about 20 paracentesis by the end of their first year of training. So things that we need to keep in mind. If there's a GI bleed, but the patient also has signs of cirrhosis on physical exam, even if we don't know of this history, like jaundice, ascites, encephalopathy, spider angiomata, low platelets, albumin, and so on. If we have any of those, we have to consider a few other interventions in the case of a GI bleed. So octreotide is a very important intervention because it actually has been proved to slow down, to decrease very rapidly the portal hypertension and to decrease the speed of the GI bleed. So it can be given as a first dose of 50 mics as a bolus, and then we can start a drip of 50 per hour. Ceftriaxone, 1 gram is usually the dose if we don't suspect SBP, but if there's signs of spontaneous bacterial peritonitis, that dose goes to 2 grams immediately. But it's been proved that people do better because sometimes even if they recover from their GI bleed, they may die of secondary infection. And then packed red blood cells. So normally the guidelines say no need to transfuse until hemoglobin is down to 7, maybe some cardiac cases 8, or if the patient has hemodynamic instability and the GI bleed is really actively going on, you might consider giving packed red blood cells even with a slightly higher hemoglobin. But things to remember is that sometimes if you over-resuscitate these people, that can again increase the portal hypertension and can make the bleed more brisk. So it's very important to balance that. So much for the GI bleeds. And then moving along towards the stroke transfers. So things we should know about those. First, you have to decide when a hemorrhagic or an ischemic stroke meets the criteria for transfer. So in the case of hemorrhagic stroke, any kind of large volume intracerebral hematoma is eligible for transfer. Concern for expanding hematoma, as well as rapidly declining mental status, especially if people require intubation, they definitely need to be transferred, and then keeping a track of their Hunt and Hess score. In ischemic stroke situations, NIH stroke scale of greater than 4 qualifies, as well as signs and symptoms of large vessel occlusion, and of course, the stroke in the young. These people can benefit from being transferred to a comprehensive stroke center. So there is a checklist as well here, just like with the cardiac transfers. It's very important to document, of course, the results of your studies. What do you see on CAT scan or any other studies you may have performed? Document the initial and ongoing NIH scale. So the time of onset of symptoms, very important, sometimes difficult to detect, as well as the time the patient was last seen normal. So did you administer any medications? Are the patients on any medications? Do they have AFib? Do they have, are they on any anticoagulant kind of medication? When was the last dose they got any anticoagulant medication? And did you administer TPA or did you not administer TPA? And if you did not administer TPA, you have to very strictly document why you did not do that, all the contraindications. And of course, if you did administer it, you have to very strictly document that there are no contraindications or that the risks are lower than the benefits. Do not forget the glucose. Make sure you document the initial glucose and also keep checking it. So what is the source of the information that you're getting? Is it the patient, or if the patient is obtunded, or if they're intubated? Who gave you that information? And also, how can you contact this source of information? Are they authorized to give consent for the patient's further interventions? Very important to document those in favor of the future treatment of the patient. So that much for stroke. So moving along kind of rapidly here, but bear with me, we're getting there. Transfers in OB cases. So 3 main areas that I would like to briefly cover is vaginal bleeding, preeclampsia, and active labor. So moving along to the vaginal bleeding situations, of course, covering the most dangerous ones in the area of painless or painful vaginal bleeding. The painless that we fear is the placenta previa, and the painful is placental abruption. So let's cover the painless one first. So placenta previa usually occurs not earlier than over 18 weeks of pregnancy. It is very important to assess the amount of bleeding and to resuscitate promptly. The diagnosis is by ultrasound. Do not place anything in the vagina. And if the patient who is experiencing this or has a suspected placenta previa and they're greater than 24 weeks pregnant, if there's significant bleed, they definitely need emergency transfer because they may end up needing an emergency C-section. So those people should be resuscitated and sent promptly to a center where definitive OB care can be provided. And going to the painful vaginal bleeding, placental abruption is the one that we fear. And the placenta separates usually after 20 weeks of pregnancy. So I mentioned earlier, in trauma, it is very important because even minor trauma, as we know, can cause placental abruption. And if you do not see it on ultrasound or any kind of other trauma imaging you have done, you have not ruled it out. You cannot rule out placental abruption with any kind of imaging study. It's really a clinical diagnosis, and those patients have to be monitored in controlled circumstances on the floor where OBGYN can do emergent OB evaluation. And if they're greater again than 22, 24 weeks, transfer them. These people may need crash C-section. All right, so much for vaginal bleed. So preeclampsia. So what is preeclampsia down the cascade of all these three scary conditions? New onset of hypertension during pregnancy, which is defined as 140/90, and it is severe if the blood pressure is greater than 160/110. And that is in combination with proteinuria, which is in combination with headache, blurry vision, right upper quadrant epigastric pain, or abnormal LFTs and platelets. And easy definition here, eclampsia is preeclampsia plus seizures. And of course, we have to keep in mind the HELP, which covers hemolysis, elevated LFTs, and low platelets. Getting dizzy yet? We're almost there. So what do we do before the transfer? Aggressive blood pressure control, labetalol, hydralazine, difedipine, these are all medications that are approved for this kind of treatment. Do not forget the magnesium, give a load and do the infusion. That's for protection of the seizures. And then transfer to a high risk obstetrics care, not any place. They need to be able to do definitive care there. And then active labor. And when I was in TRC, these were my most scary patients. I had no OB backup. I had no pediatrics backup. So whenever a pregnant woman walked through the door of that tiny ER and said, I'm in labor, and that was my biggest fear. It is pretty critical. So EMTALA, again, as I promised about this, according to EMTALA, which is Emergency Medicine Treatment and Active Labor Act, a pregnant woman who is in active labor must be admitted and treated until delivery is completed. And keep in mind, this includes the delivery of the placenta. And this is what a patient in labor is considered stabilized under EMTALA. They have delivered the baby and the placenta, that is stabilized. And unless the transfer is under the statute is appropriate. And this is a very, very tricky situation. You really have to document their emergency medical condition and that you have done the appropriate screening exam, which in this case includes checking for the degree of dilation and also checking how often the contractions are. And really these patients, I had to do that last check. They were on the monitor, on the TOCO monitor, and they had their last finger exam on the stretcher out the door before they got to the ambulance, before I transferred them out of TRC. So there's a very strict restriction on transfers, and the institution has the duty to treat these patients until stabilized, or otherwise you have to have a very good documentation why this patient is better off being transferred than waiting for the delivery at the transferring facility. And getting to the last drop here that I would add on to the OB transfers, which is not exactly an OB transfer, but we're also a SANE transfer, a SANE center. And in many outside facilities, you might be required to do these SANE exams. I used to do them in TRC. We had a famous serial killer there whose victim ended up being my patient a long time ago. But anyway, so covering the same exams is very, excuse me, important if you cannot perform that exam to transfer in a timely fashion. So this is kind of a busy slide, but there are several things I would like to point out. First of all, it is an ED to ED transfer, and only the MD can accept that transfer. The same provider cannot accept those transfers. We just have to make sure that they're available. So when do you not transfer them? So the guidelines change, and this is the most recent one that our nice SANE team provided to me actually a month or two ago. So if the sexual assault occurred within 120 hours, they're still eligible for that exam. If it did not, oops, I am so sorry about that. I'm too hyperactive with my fingers. If this does not meet the 120-hour criteria, no need to transfer. Also, does the patient agree to have the forensic exam? I recently had a teenager who was transferred, and I accepted the transfer. And when she showed up in my emergency department, she said, I don't want the exam. I was never told that I have the right to refuse. I'm like, well, yes, you do have the right to refuse. So we need to check, did these people agree? If they did not agree, no point transferring. And then if the patient is not stable, they have other trauma, things that need to be treated before the sexual assault exam, they should not be transferred just for the sexual assault exam. Importantly, if all those criteria are met and all these are yeses, mandatory reporting has to be completed. I had recently a case which I accepted for a patient who was in our department for SANE exam, and we could not perform it because the police had not filed, had not examined the patient, they had not created a case number, and all these things were not completed. And many hours later, when the police showed them, I said, this patient doesn't meet criteria for that. This patient was, let's say, prostituting themselves or something. So it's very important to have all those clarified before you transfer this patient for the SANE exam. And I think that's it. So I am open to questions if you have any.
That's amazing. Thank you, Dr. Wells. And, that was at a blistering speed and dizzying and wonderful. But to be honest, that's how quickly our transfers need to happen at these rural sites and centers. I mean, we all know that we can see a patient almost from the EMS call. We can understand that they're likely going to need a higher level of care, and we should already be enacting our protocols. If I had to take a summary of what you put forward, what's very, very important is the transfer agreements that need to be in place prior, meaning speaking to your accepting facilities, you know who they are, and making sure that you get the appropriate stakeholders into room so you can give them your practice context, what your resources are for these very high-risk patients and high-risk transfers. That's going to make the follow-up communication all the more easy. Secondarily, I think it is gathering the teams around this patient and maybe stating up front that you believe this patient is going to need to be transferred, and your goal should work through that stabilization and that packaging of that patient in a responsible way to get them there. We did have some challenging questions, and I really like this one from JBack. That is, we had some issues transferring patients from our inpatient unit. So let's say that we have a patient admitted through our ED to an inpatient unit and then has an acute medical complication that is outside the scope and resources of our hospital, and we decide to transfer them. Now, this one happened to be a variceal bleed, but let's say it was a fall and a transfer and an acute subdural. That in our emergency department, if it came through the ED, it would be a trauma, an ED to ED transfer. But from an inpatient unit, they were having a significant amount of bounce back to say it can't come to our ED because it would be an EMTALA violation. I'm not sure if EMTALA applies when you're there on the inpatient floor and trying to transfer a patient for a medical issue or a new traumatic injury. But could you speak to that? How would your facility handle another inpatient unit wanting to transfer to your emergency department for a patient that clearly is ill and is outside of the scope and resources of the sending facility?
So the one of the positions of EMTALA is that the transfer has to be appropriate. In other words, it has to be to a higher level of care. So emergency department in general is not considered higher level of care than an inpatient unit. So we accept transfers like this, but with the agreement of the service who is ultimately going to take care of that patient. So we need to have the trauma team on board, or the GI team on board, or the ICU team on board. And they are ultimately the accepting service, but we are happy to see the patients in our department and further stabilize them. It's not unusual we're a trauma center. We frequently have trauma patients coming from an outside facility, and the trauma team meets them, but they need some stabilizing intervention like intubation, fast exam, procedural sedation. All these things we can provide as emergency physicians in the emergency department, but ultimately we do need to have the backup of the facility and the administrator on duty. We have to make sure that we do have the bed availability and all the capabilities to take care of the definitive need of this patient, the definitive treatment.
Another question that we had, especially with all the issues of capacity around our particular area, that there was no ICU and very minimal inpatient capacity and multiple patients boarding in the emergency department. So for a lot of our transfer facilities, they were saying no. So even though that that is a designated higher level of care, they still needed to make the justification or the explanation of why they did not have capacity to take patients. What is that trigger for your hospitals? I mean, in what circumstances are you saying that Texas Tech El Paso could say, no, I can't accept this patient? And how does that conversation take place?
I still have not had the chance to say a no. I don't think we say no, especially since we're a level 1 trauma center, comprehensive cardiac and stroke center, mother and child center, and all these things. I think we pretty much accept everything. And when we had this overflow of patients, we even created our own ICU in the ER. It was an ED ICU where we were keeping the admitted COVID patients. Actually, Dr. Norquist, who is talking right after me, he was really the expert running all that. So I am not aware of us ever saying no to any kind of transfers. We just go with whatever we can do, and especially for trauma patients, those transfers happen very rapidly. I don't think we can possibly say no. We just open the tents or whatever we need to do, and we even have accepted transfers from outside facilities. They go straight to the tent nowadays, and we still do it.
Just say yes. I love it. Thank you so much for your time today.